Great. So thank you, Beth, and good afternoon, and welcome to the 8th webinar in our Integrative Practice Webinar Series here at the Academic Collaborative for Integrative Health. My name is Deb Hill, and I'm on staff here with the Collaborative, where I help to facilitate our working groups and projects. So next slide. So this webinar is an outcome of the work done by our Integrative Practice Webinar project team here at the Collaborative. I want to thank this interprofessional team of volunteers for all of their work. Next slide. So as stated in the previous slide, our goal of this project is really to increase the understanding of integrative practice by hearing from those currently practicing in these environments. So topics covered during the series include models of integrative care, collaboration, communication, patient management, challenges, and innovations, especially as we move forward into the era of COVID. The next slide. Other webinars in the series can be found on our website underneath our working group tab. So I welcome you to peruse those, and you'll see there's working group presentations there. Next slide. So I want to thank you all for answering the registration questions ahead of our time today. Here's a snapshot of your colleagues joining us today. We have a broad range of roles in integrative healthcare represented from students to administrators. And next slide. And also a broad range of experience levels, from those of you who are just learning about integrative healthcare to those with formal training. So hopefully this gives you an understanding as to the reach of our talk today. So without further ado, next slide, I welcome Integrative Practice Webinar Project team member, Paul Rattay from Northwestern Health Sciences University, to introduce our guests and get us started.
Thank you, Deb. I'm very excited to introduce the two presenters today. I've known them for a number of years personally, probably 20 years maybe, Jennifer. You know, I need to give a lot of credit to Bill Manahan, who's a retired medical doctor and a past president of the American Holistic Medical Association, who really has put together a group, a holistic, a chapter of the AIHM in the Twin Cities. We have basically 483 different healthcare professionals, and we get together, not in the last year, in the last, like 2 or 3 times a year to kind of share stories and get to know each other. And so he's really done a really great job of, introducing me to integrative care, and that's how I've met both Sue and Jennifer. So with that, I'll give you a brief introduction. So Jennifer Blair is an integrative holistic provider. She has clinical specialties in acupuncture, Chinese herbal medicine, dietary therapy, and integrative health coaching. She's a licensed acupuncturist with a master's degree in Oriental medicine. And in addition to her work at Penny George Institute for Health and Healing, Jennifer serves on the adjunct faculty at Northwestern Health Sciences University. She's also the first acupuncturist to serve on the board of the American Holistic Medical Association. So welcome, Jennifer. I will also welcome Susan. Hopefully she'll be in very quickly. I know she's seeing patients. We have, busy practitioners here. So Dr. Susan Haddow is a medical doctor, and she's trained in integrative, holistic, and functional medicine in addition to conventional family medicine. She's board certified in family medicine and integrative and holistic medicine. And she's also a certified practitioner with the Institute for Functional Medicine. And in addition to her work at the Whittier Clinic, Dr. Haddow has been actively involved in research at the Center of Spirituality and Healing at the University of Minnesota. So with no further ado, I want to open the floor and get that introduction from presentation from both Jennifer and Susan. Thank you.
Thank you so much, Paul. And since Susan here yet, I'm just going to go through the slides quickly to get to yours, Jennifer. How does that sound?
Yeah, that sounds fine.
Whoops.
A little bit too quickly.
Yeah, I know. Is this your first slide, Jennifer?
Yes, and you can click, we can go to the next slide. So I just want to say thank you to the Academic Collaborative for hosting this series of webinars. What a wonderful way to get people in relationship with one another, thinking about how we can continue to work together, to share our experience so that we can all grow what we know to be a really healthy way to approach human health on a global level. So I'm really delighted to share a little bit about the history of the Penny George Institute. You will note that it has turned my hair completely gray since the last photograph that you saw up there. That was taken about, must have been, I think that's a photograph from Northwestern Health Sciences University, and so it's probably 20 years old. So forgive me for that visual lie. This is the real me now after 15 years at the Penny George Institute, but it's hopefully the wisdom I've developed, not the stress of being a provider. I'm really excited to share a little bit about us. I can't see any of you, so I'm just talking to myself, but please, if you have questions, I'm not sure how this works, if they go straight to Paul, but I'm happy to have you interrupt me, or I'll let Paul just determine what's good to interrupt me with. So I'll just go through for any of you out there who may not be at all familiar with the Penny George Institute. We were founded back in 2003, and the Penny George is actually a real live human being who had a very significant experience that I'm not out of school sharing. It was actually published in an article in the local paper here. She had breast cancer, and she sought out integrative and holistic healers to help her through that journey. When she tells her story, she shares that she received exceptional oncology care, but she felt that there was something missing. They were really good at treating her disease, but she needed more. And as a result of everything that she received during her journey through cancer, from acupuncture and shiatsu, and I believe she even did a walkabout in the desert. She really felt that this is something that should be available to all people, and the insurance system, the current medical system, was not that open at the time to what we might have to offer, and really didn't know what to do with us or how to slot us in. So she had the bold vision to bring it in. She worked with our first director, Lori Knudsen, who is now moved on through many iterations and is continuing to build across the country, locations like ourselves, to start the Penny George Institute for Health and Healing. We quickly became the largest integrative health program in the country that was embedded within a health system. So between 2003 and 2010, we really were paving the way. Sue Haddow's clinic was also, they were coming alongside of us and building Whittier. So it'll be really nice for you to hear both sides of this. If we jump a little forward, as of March 2012, we were doing so well that Alina, our mothership, decided to make integrative medicine a service line across the organization, which from their perspective elevated us within the system, allowed us to bring in a medical director so that we could have leadership that could talk to other leadership across the system. So talk to cardiology, talk to oncology, talk to orthopedics, and give us the same level of status in the organization, which was really a good way to begin to help us to embed. We can go to the next slide. The note at the bottom of the slide about the transition to from hospital-based clinic was really about how we changed our view to insurance providers. So that's a detail we can discuss later if people are interested. Quickly, our mission and vision have been tweaked over the years, but our current mission is to combine leading medical practice with ancient healing wisdom to optimize health and wellness in the whole person, mind, body, and spirit. So the combining leading medical practice was really a way of acknowledging this concept of integration and that we are part of an existing medical system. I think early on, we were the interlopers. We were the ones who were upsetting the status quo. And over time, we've become more and more accepted and integrated. And so the mission and vision changed a little bit to accommodate that we were actually becoming part of what already existed. So the guiding principles, I'm sure you're familiar with these: patient-centered, customized, which is really important to customize to the individual. That's part of holistic integrative care. We can go to the next slide. I have 9 slides and I'm probably not talking fast enough. So if you look at this slide, you can see all of the different approaches through integrative health that we have providers addressing. Everything from biofeedback, music therapy, we have a whole fitness center, we have health coaches, we have really made strides within the organization with employee health through our well-being programs that are part of the insurance package for all employees. So we've done everything from vitamin D testing back in early days to providing health coaching to employees as well as to patients who might seek us from outside the organization. We have teams of integrative docs, acupuncturists, and nutritionists at sites across the system. And there's a list of sites on another slide. And we have flexed as we've grown. We started out as inpatient only. We were 22 providers seeing patients on the hospital floors, to opening a clinic and then developing another clinic, to now being embedded in primary care across the system. Next slide. So the inpatient program, that was our initial, started in 2003. You can see the list of practitioners. We would work as teams. We would work as a whole team. In the morning, we would be passing around patient charts saying, oh my gosh, you have to see this person. This is a perfect one for you, Mary Ellen. She needs the kind of guided imagery you offer. Jennifer, please go see this person on rehab with a spinal cord injury. They need acupuncture and Qigong exercises. So we really would meet every morning as a team, discuss our entire list of patients, which could be, 60, 70 patients a day. Actually, 22 providers times 8 patients each. So you do the math. It's a lot of people, but we would be sharing with each other who'd be the most appropriate person. So we had music therapy, guided imagery, healing touch, Reiki, Qigong, massage, and we tried to bring the most appropriate therapies to the people who needed us. And some of the early referrals we got were from nurses and doctors on the units who had patients who they'd done everything they knew how to do and there was just something missing. So was it, oftentimes it was a healing that was needed rather than an intervention, a medical intervention. And one of the things we noted over time is that the people who were labeled frequent flyers stopped having to come back. The people with chronic comorbidities stopped having to come back so much because we'd open the doorway to avenues of self-care and other ways of being outside of the hospital environment. So, so we really embedded ourselves in the hospital setting in a way that developed relationships across the system. Next slide. So this is a list of the hospitals where we're operating right now. At Abbott Northwestern, we, as I said, we're flexing. Right now, we have a more focused approach. Rather than being across the hospital, we're focused on oncology, the joint replacement camp, and mother-baby. We were in the emergency room for a couple of years, and they just haven't figured out a way to bill for us. So we're smaller now and a little more narrow focus. And you can see the other hospitals. Next slide. Has Sue come on? 4 minutes ago she said she's coming. So again, the inpatient program, that purpose was to develop awareness and understanding of an integrative approach, to bring in our modalities in an acute care setting to support a more comprehensive plan, and empower patients and staff to engage in their own healing process. And next slide. Here's a view of our outpatient clinics, and you can see a listing of them. The outpatient clinics serve as a standalone option for patients who want to seek integrative care within the confines of a medical system. There are some people who prefer to see people out in the community in private practice. There's a certain subset of the population. And then there's a subset of the population that just feels comfortable and safe in a medical system. And this was a way to bring the kind of integrative care that people were sort of cobbling together out in the community into a cohesive group. So one of the beautiful things we did was we would meet weekly and have the entire clinical staff discuss patient care, discuss how we could cross-refer. There were a lot of hallway conversations, and there was also dedicated time provided to us to discuss how to best help a patient navigate the system. And next slide. So a list of the services, again, you saw this on the early slide in terms of what we were doing.
I can hear you now. Can you hear me?
Great. Is that Sue speaking?
There's Sue.
Yeah.
That's Sue. We can all hear you.
Good.
And I can't see you because my GoToWebinar, I thought I had it everywhere, but it is not the case on the phone. But and I don't have a camera on my computer, so I am so sorry. So you can hear me but not see me. Yes. Thank you.
The audience can hear you now too. So I'm just going to finish up my slides and then roll over to you. Does that sound okay?
Perfect. Thank you so kindly.
Okay. So here are the outpatient services and locations, that listing. And, you know, when the questions start rolling, I'll certainly go a little deeper, but why don't we go on to the next slide? Is there a next slide or am I done? This current landscape, I just want to offer these as questions for possible questions and things to discuss later. I think one thing I'll touch on briefly is integrative grand rounds. I started that. It wasn't a formal grand rounds, but what we did is bring integrative providers together around a case, and sometimes we'd have a conventional care provider as well, and we would invite other staff within the hospital system to come and join us as we discussed. Now here's a patient, an example of a patient who was maybe hospitalized on the antepartum unit with a threatened miscarriage, and we would talk about the variety of integrative tools that were brought to the bedside to help her maintain her pregnancy. We brought a breast cancer patient who we had her conventional care and then all of the integrative approaches and how they all dovetail together. It was a really great way to bring both providers across the system in conventional care to develop an appreciation for the work that we're doing, whether it's nutritional intervention, acupuncture, integrative physician, but for them to understand and deepen their appreciation for how we can be part of the team. And I think the other stuff, I'll wait till the end. We can come back to this slide. I'll let Sue go through her introduction, and in the interest of time, we can talk about some of these things later.
All right. Thank you so much, Jennifer, and welcome, Sue. And Deb just texted me that she had a problem with GoToMeeting, so she's on by phone and not able to see questions. So, Paul, if you can handle that, that'd be great.
We got to get them ability. I can't talk. Sorry.
Sue?
Hi, I'm trying. I think I actually might be able to get on by my phone now. And hello. Yes, I can do my slides. Hello. Thank you all. There's never a non-surprising moment. And patient care is messy. That is the bottom line. So I can't control the slide, so I'm going to ask you to move to the next slide. Thank you. Hello, everyone, and thank you again for your patience. And unless I can control the slides, which I don't think I can.
Nope, I've got them, Sue. This is Beth.
Okay.
Hi. So just tell me when you
just go ahead and switch.
Okay.
I can.
Great.
So you may have already gone over this, but I love to restart with, you know, what is integrative medicine? And I like to think of this, and we teach this to our residents. Integrative medicine is the practice that reaffirms the importance of relationship between practitioner and patient, focuses on the whole person, makes use of all appropriate therapeutic approaches, healthcare professionals and professions to achieve optimal health and healing. And I love that from the Academy of Integrative Health and Medicine. Setting the tone. Continue, please. So a quick brief history of how is integrative health here at Hennepin County Medical Center. And it started really back in 1990 with Pat Culleton, who brought acupuncture and the alternative medicine clinic through the internal medicine department here to work first with addiction initially, and then it grew over the years to the point where we have now acupuncture, chiropractic, and holistic physical therapy all downtown. We have chiropractic and acupuncture services to all of our outpatient sites, Whittier, Brooklyn Center, Golden Valley, and, well, the Be Well Clinic is not working right now with COVID, but the Be Well Clinic as well. And to the point where we have our chair of internal medicine is an integratively trained physician named R.T. Prasad, and she is the first integrative chair of an internal medicine department in a large system in the country. So we're very excited about that. And next slide, please. And then at Whittier in particular, we've grown through the years, starting with back in 2010, Drs. Selma Sroka and Kara Parker had really began to establish their very small little practice initially in our family medicine outpatient practice. And Dr. Sroka and Dr. Parker both at different times worked downtown at the alternative medicine clinic as it was known until about 6 years ago. And we expanded services over time, and I came on board in 2012 here to do integrative and holistic primary care. We expanded services to include a chiropractor and acupuncturist in 2013, and we had integrative physical therapy for a couple of years, which is now only downtown. We also have an integrative health physician's assistant. We have a women's health specialist who does a lot of integrative work. We have a nutritionist, 3 MDs, 1 RN, and a dedicated scheduler until COVID sort of shook up a lot of everybody's roles. And we have the integrative medicine and residency curriculum through the University of Arizona, with which we use to train residents in all 3 years of family medicine training. Next slide, please. And that's what our website looks like. If you go to Integrative Health Primary Care at Whittier, and you can find a provider, which, by the way, we have pretty much closed practices, but you can just Google Integrative Health Whittier Clinic, and this is what you'd come up with. And as you, okay, next slide. So what's working well, as Paul asked, at our Whittier Health and at Hennepin County Medical Center proper? We are full. In primary care, we have a very low no-show rate for all of our practitioners, actually, for acupuncture, chiropractic, primary care. We are full. We make referrals to each other within the system. That works well. We get to teach residents. They get to rotate with our chiropractor and acupuncturist and nutrition and women's health. And so they get some insight into what do the breadth of practitioners offer and how and when to use those services. We offer consultations to our colleagues for patients they're struggling with or who are curious and need the kind of thought process we put into things. We've developed a group visit program, which has been functioning for about 5 years now, and we'll go into that in a little bit more depth. And with the COVID, we've developed a supplement support package for immune health that's really affordable for underserved patients, and a lot of our staff are taking it, actually. And it has zinc, and sorry, I made the wrong one. It doesn't have quercetin, it has NAC, turmeric, A, C, D, and melatonin. Next slide, please. There's probably more going well, but that's what all came up first. But challenges, this is an interesting thing. So one of the challenges is that the same thing that makes it successful is demand exceeds capacity. And we are trying to do more consultations, but we don't have enough trained faculty. We may not have enough capacity to hire people to do the primary care work that is needed. We're trying to train our residents to bring this set of tools into their day-to-day practice. We have support to do that, to continue with the Integrative Medicine and Residency Program, and I precept with residents, and Dr. Parker is training residents in group visit format. So that's helpful. We have inconsistent insurance coverage for acupuncture, chiropractic, and nutrition, and that is not good. And we also, on that, I'm sorry, are you guys getting reverberation on this? Or is it just me?
Just
okay,
you.
All right. Thank you. That I can deal with. Is the acupuncture, chiropractic services and somewhat nutrition as well, they're kind of still siloed. You know, they're out there. These acupuncture, there's nutrition, there's chiropractic. Where is our group connection? How do we really, really integrate across our systems? And that's been a real challenge, and that leads me right into this: no dedicated meeting time to grow our practices, our integrative health department as a functioning, strong department across our system, to do case management, to develop research, to create more educational bridges. There is just not a lot of energy or resources dedicated. Plus, we have these new E&M codes that are going to be coming out soon that'll be a little problematic, and we'll figure out how to work with those. And then one other thing that didn't get put on this slide, though, is this polarization that's going on across the country and probably even within our systems of, you know, here's all the evidence-based care and this is the only thing that we can do, and anything that may be a little outside the box that actually supports patients' health and well-being and is actually helping them is suspect in a way, because there's no research behind it. There's no evidence. Of course, a lot of what we do in standard conventional care has no firm evidence either, but that's a whole other discussion. And I mean, I would love to see where we can practice truly more side by side. And for example, our acupuncturists do amazing diagnostic work. How could I partner up with my acupuncturist diagnoses on a very fundamental, on-the-spot level where we can really integrate our services to the health and well-being of that patient? And that might save a ton of cost in tests that don't need to be done, and, you know, all kinds of things. And we could actually help validate a lot of stuff, and it would be so cool. Anyways.
Hey, Sue, can I jump in just on something?
Yes, please.
You know, the last 3 bullet points on your slide point to, you know, something I said as well, that it's the financial challenges and the financial pressures that are driving us, you know, over at Penny George, it drove us to narrow down our inpatient teams. And I also want to say that this idea of polarization, I completely agree with as being a primary challenge. And also that it's not true that there's no evidence. Not that what you're saying is incorrect. It's just that there's a perception of no evidence, but there is quite a bit of evidence. It just takes more for people to accept us. And what has been my experience is that we give people evidence, but they're not ready to hear it yet, or they don't have the financial bandwidth to invest, or they're being pulled away in survival mode to lean more in favor of high dollar reimbursement interventions. You know, the healthcare system gets reimbursed for expensive procedures and doesn't get reimbursed well for primary care or integrated care. So there are a lot of disincentives.
And the new E&M codes will not make that any better. I'll just tell you, they've not improved that. And then I'll thank you for bringing up the inpatient thing, because I think that's where we're truly missing the boat at Hennepin, is we do not have any inpatient services whatsoever. on either any consultation team or providing acupuncture or chiropractic services to inpatients.
And here's an idea that I heard yesterday from another provider that I thought was brilliant. He suggested that, with the financial squeeze that healthcare is feeling right now, it may be that hospitals are going to be less inclined to take on employees for inpatient care, acupuncturists as an example. And he suggested that the model that we see with emergency room physicians is something we might consider, that where you build a company that owns and hires all of the integrative providers, and then we get contracted out to organizations. And I thought, oh, isn't that a nice way of avoiding the challenges of trying to get a foothold all the time, but just saying, yeah, we'll take on the risk because we know it's worth it. So there's something for an entrepreneur out there, if there is one in the audience.
Very good. And next slide, please. I briefly wanted to mention COVID-19. For nearly 3 months, we didn't do routine care for anybody. We've developed, as I think all the systems have, some telemedicine, which has been truly helpful, the supplement package, and we cannot do any in-person group visits, which we were really robustly growing, and that's been a real problem. Now, the other thing that's not on that slide is in terms of COVID-19 and people recovering from it and the long haulers who are out there with symptoms that are persisting over 3 months. I think there's going to be a real need to help investigate and manage these patients. And I think a functional and integrative medicine approach with all of the integrative providers that it shows on the definition from the ABIHM of what is, or the AHIM, of all the different providers that are, and practitioners that are part of taking care of patients that are evidence-informed, are going to be needed and helpful in our long-term COVID recovery patients. Next slide, please. And then group visits, if anybody has any experience, I don't know, but we are loving them for both patients love them, and providers love them. They can be so reinvigorating. And patients don't, I think it's one of the good cures for loneliness, which we see a lot of in our patients as part of an unfortunate angle of unmet need. But also people learn from each other, and it's great. And we've really enjoyed it. And we've had, if you go to the next slide, I can show you the different offerings that we've been having. Rest and Renewal with Dr. Parker, Living with and Preventing Diabetes and Heart Disease. Dr. Stephanie Stevenson runs that one. I do the Tame Your Pain Beyond Medication. Kara does the Functional Medicine group. I'm going to be doing a Bone and Structural Health Awareness group. And then our PA has offered Life Beyond Cancer groups. And so these are what we'd call more kind of closed groups. They usually have a bit of a curriculum sort of thing. We expect people to learn. They're 6 to 8 weeks. So the Rest and Renewal group is kind of a drop-in group. And that one can be whomever, whenever. And it's more sort of group empowerment, and they make a lot of decisions there. And so that's kind of what I have to share right now. So thank you for being so gracious in my tardiness. I'm deeply apologetic and not a little embarrassed, but thank you. And so if we want to go into some questions.
Yes,
or comments
please,
or thoughts.
Please, no need to apologize, Sue. We are so appreciative of you and Jennifer being here and all the prep work that went into it. Let me just scroll down now. We already went through Jennifer's slides, and we're into discussion now. And Deb's screen is frozen. I don't think she'll be able to participate by voice.
Yeah.
Can you, Deb?
Unfortunately, no, I'm via voice, but I cannot.
Okay.
Yeah, I'm completely frozen. But if I close out, I'm worried I'm going to crash the whole system.
All right.
So, Paul, I think that there might be some questions, or I know that you have some great conversation prepared as well for our presenters. I'll let you take it from there.
Thank you so much for presenting. So there certainly seems to be some interest on Jennifer, you talked about the grand rounds. like, are they recorded? Have you done anything to, offer something like that as a continuing education? Because I bet there's a lot of interest in having, seeing or experiencing how you're integrating with actual patients.
We actually have recorded them. I don't know if we've made it available for people outside of the system, but it is available for employees within the system.
Yeah, so I would think there's a demand for that, so that would be something you could maybe leverage in the future.
Yeah, it's interesting because I think the system itself, for many years we have talked, when we were sort of leading the fray early on, we kept saying, let us loose. We want to, teach nationally. And we had a couple of week-long training for acupuncturists to work in integrative care. That was in 2007 or something. But Allina as a whole is a little bit protective. We work within our own system, it's an interesting challenge. We would certainly, as providers, we'd love to see an opportunity to be more out there. And I think individuals, I've spoken at the academy and other places, but it's a good question, Paul. Appreciate that.
Yeah.
And I can pop in here for just a second too. We've been invited over to HCMC a couple of times in the 8 years I've been here, I think twice, to do some grand rounds on what is integrative medicine to the larger community. So that's not terribly robust, twice in 8 years.
And, grand rounds is an interesting egg too, because it has a rubric, and it's elevated in a position that I don't think they very quickly receive the idea of integrative and holistic care into grand rounds. But so what I did was, when I started it, I made it very informal, and I wanted to, I set it up with the presentation was according to a grand rounds, but to make it less formal and make it more of a discussion group was really helpful. And I think now our leadership wants to kick it up a notch and then bring us into the oncology department and, set us up there. So it takes generations for this stuff to stick.
I think you're right.
Yeah, whoever's on the call who's next in line, the one with there's someone in the audience who's got a lot of passion and a lot of fire. Know that, we have that too, and it's a slog sometimes.
Yes, agreed.
Thank you. So there's also, I see some interest on the group visits. One question was, how long are the group visits? And I'm always interested in, again, you said you had drop-in and then sort of more formal group visits. Is that the drop-in? Anybody can access that? Is it only for existing patients? Tell me more about the group visits.
Yeah, so in general, they tend to be somewhere between 90 and 120 minutes, so between an hour and a half to 2 hours. That's how ours are set up. The drop-in group tends to be people who have been through other groups already, and then they come back, although people do find their way there. We have, so how do they find their way there? That, I think, is our biggest problem in group visits, is the recruitment strategy. We have signs around the clinic about what they are and who's leading and what to expect. A lot of people are just sort of weirded out. They're like, oh, a group visit? That sounds really weird. What is a shared medical visit? And so we're trying to work on, and that's not just patients, but other practitioners too that don't really know what to expect. So what we really want to do is make a little video that we can put up onto our staff website and the HCMC website that both staff and patients can access, that's like a minute and a half or something, that has some testimonial, has a quick thing about what this means. Because we've had people come here, thankfully, for example, sent to me from the pain clinic downtown, the interventional pain clinic. And we reached out to the nurse practitioners and the docs there and sent them a few things to let them know, and they're like, yeah, okay, well, whatever. And one of them actually sent me a patient And the patient came and said, I really didn't know what to expect, but she is now a primary care patient with our team here at Whittier and has been sold on this approach, and whole person approach.
Yeah.
So, I mean, I think, you know, go ahead, Jen.
It takes that having a real lived experience of it. You know, I've often found that with when a provider, I had a cardiologist come to see me. He said, well, I'm doing some research. I'm going to see what this acupuncture is all about. And he had this blown away experience, which, you know, I don't take credit for that. It's the medicine itself that just made his mind click in a different direction about how this might be part of care. But if you're not trained or understand these approaches, how would you know? You have to kind of experience it. And I just want to say we do group visits over here as well, and our biggest challenge, I think, has been financial. People are really interested and really excited, but if insurance doesn't cover it, that's a, you know, that they can push back. And sometimes it does and sometimes it doesn't. But we've had great success with menopause. And I think women understand that being in a room with other people who are having a shared experience can be useful, especially if they've already been to one of our providers and they know how we work. They feel safe here and they feel like they can trust people. You know, they don't go to the idea of like group colonoscopy or group surgery. They think, oh no, it's a safe environment where I can share. And we started our group visits actually with mental health. Henry Emmons developed an 8-week program in resiliency, and he brought in nutrition and Ayurvedic approaches as well as neurological understanding of resilience. And then we've had follow-up open visits where after people had completed the 8 weeks, we would have a monthly session where people could just drop in. We've done menopause, and then we have a group pain where it's an acupuncturist and a physician working together, teaching Qigong to patients, as well as giving them a neurological understanding of pain. So different sets of challenges in different organizations, I think, which is interesting. And ours has really been financial more than acceptance.
And I have to tell you that I'd say this is where our treating the underserved, we have so many Medicare and Medicaid patients that they actually are able to access our groups more readily than people with a third-party payer. So this is a really interesting flipping it on its head, you know. That people often say, you know. So this has been a boon in some ways in that way. And we build a 99213 for the most part, and that's been okay. And if we can see between, you know, if you can get 12 99213s, that sort of equals, you know, what people were doing in a clinic session. And it's shorter. So, I mean, if you could do 2 a day, boy, you would be doubling in terms of finances,
and
you know, so interesting.
You know, our financial piece has been more from the Alina's perspective, I think, because I know menopause has filled and they've been able to bill it, but the commitment from Alina, like especially to bring an acupuncturist in, they had no idea how to bill us. So we were, the 99213 was
whatever you guys do,
was covering the acupuncturist as well. And so how do
that's
we
not going to be cost effective, right?
Right. So they have a hard time committing. But we did just start. Our nutritionists are doing a blood sugar group visit. They're going to do it online. So that's one of the blessings of COVID is we can do a telehealth group visit and educate people about who may be at risk for diabetes, about how to manage their blood sugar. So sometimes in all these problems come creative solutions that allow us to address a problem that the system can't. And I would encourage people out there that that's where you start, is find a problem that your system can't address and show how you can help, and that'll get you a foothold.
Absolutely, yes. And just curiously, the psychiatric world has done group therapy for a long time compared to us finally doing some shared medical visits. That's been a model, I think, that's been out there for a while. And we had an acupuncturist try to come do some groups with us, and they have to be able, we worked on trying to have them bill actually as the acupuncture units, and they'd have to do a certain amount of time with each patient. So, I mean, it does get a little fussy. And then same with psychologists, you know, because they're in a different practice from the family med docs who are generally running the groups right now. Anyways, but I agree with you. Find the problem that's not being well addressed or that the community feels is an issue, and, you know, building a group around that. There's the Integrative Center for Medical Group Visits. If you haven't been there, you should check it out. Dr. Jeffrey Geller, who's a family doc from the Northeast, has developed group visits to, he's kind of called the grandpa of group visits, so he's not that old. And he does trainings for people of many different practitioner types, and has the open and closed models, and has a really good format. And we have moved to doing our groups online now as well. We're doing Zoom groups. It's not as satisfying in some ways, but it's still some energy sharing.
Great, thank you. I have a question about, have either of the organizations gathered satisfaction data? I would imagine that patients are very satisfied with the services that you're providing, but I wonder about the other players, right? So your colleagues in other departments, like, what's been their perception of you? And have you collected that data to see that there's maybe been a change in attitudes or acceptance?
Well, we have had, you know, everyone has a Yelp review right nowadays.
Uh-oh, I don't look at that.
Right. Alina has committed to publishing online reviews of our providers. I'm not exactly sure how they're doing it, but, you know, from the very beginning, you know, simply because we're not the shoot that conventional care has become, that it, can feel rather impersonal at times. You know, the environment, you know, one of my slides, you could see the environment that we have there. It's a peaceful environment in our clinic. It's very non-clinical. So the minute they walk in, they feel comfortable. You know, the way we approach care, the level of, the lack of formality, the relationship-based, you know, a relationship between patient and provider, all works to give us great reviews. I think the challenge in terms of other providers across the system is still a lack of understanding. There's a great divide culturally, and I think until people come and experience it or have a patient who's had a good fit, it's hard for people to wrap their heads around it. And I have to say that my colleagues in conventional care have so much pressure on them to take care of keep so many plates in the air. They just don't have the time or the luxury to come over and see what we're all about. So we'll let leadership sort of take that for us and develop the relationships across the system, which is why we had a medical director for a time, and that was her job, to meet with other medical directors and discuss how we could work together mutually. But in, you know, current financial times, we no longer have a medical director. We have other leaders in the system who are continuing to try and build relationships across the system, and one right now is with oncology. How can we be an alternative to some of the cancer centers of America and places like that will provide a holistic approach in addition to exceptional conventional care. So I don't know if that quite answers your question, but it's about as good as I can do. We're not giving surveys to docs, but we do. I'll make a point of, if I get a referral from a doc, I make sure I copy the note to the referring physician within the system so that they know I want to work with them and want to collaborate.
And I'll give a two-pronged answer. I'll give one from the patient says, you know, we do these, everybody has to do these Press Ganey surveys, and I'd say that, you know, in terms from the patients, we get pretty much high marks all the way around. The biggest problem is, you know, can't get through on the phone. I have to wait a half an hour on the phone to get anywhere. Those kinds of things. We have lovely building here at Whittier, and the new clinic downtown is really nice too, although they're definitely clinical. They're not as just warm and fuzzy as when you walk into the Penny George Institute for Health and Healing, and you've got water and sound. It's really quite nice. We do not have that. In terms of relationships with other providers throughout our hospital system, I feel like it's been a garden that we've been growing, and it's slowly starting to sprout. And it's variable across the different specialties. Since we do, as primary care integrative physicians, we do a lot of referrals back and forth to our various specialists across the system. And when I find somebody who's open-minded, who is curious, and who says, oh, what an interesting idea, and these things are helping the patient, then they get more referrals than other people. The other side of it is, even my own chairman, until he retired just a couple months ago, used to say, I really don't know what you guys do, but keep doing it because the patients really like it. Yep. And so that's like, okay, even we try to say, hey, look at this, we do so-and-so. He's like, okay, that's really good, but like my other colleagues here, when we talk about getting them access to the IMR, for example, they're like, I can hardly keep up with what I have to keep up with to keep board certified, let alone adding that to my plate. And then, so that's been a struggle that way. But we do find that our colleagues are certainly open, and they're grateful and curious for the most part. But they'll say, go see Sue for that. Go see Kara for that.
We had the same response. The president of the hospital, I was in a meeting with him 5 years ago, and he turned to me and said, I really don't know what it is you do, but you have changed the entire culture of care at this hospital. And then they cut our staff.
Yeah.
So, you get 2 steps forward and 1 step back, and it is all about relationships through time.
Yeah, so we have to keep sowing the seeds, pulling the weeds, and watering.
I like the way you say that.
Great metaphor.
And I just also want to add one thing to what Sue said. I think an advantage, so you mentioned we have this lovely clinic, and that was provided by philanthropy, which is a way, which gave us a foothold, someone demonstrating that this was a valued addition was really helpful. But in terms of sustainability, I think one of the approaches that HCMC has is that you are primary care, and we have, over time, that's what we've grown to do, is embed teams within primary care, and that's the next step, is having having an acupuncturist, an integrative physician, and an integrative nutritionist in our primary care clinics really does help us move across the system, and I think you guys already have that, so I think you have an advantage as well.
Well, thank you, and we're trying to just continue to grow the connections and, the synapses across the system.
I know there are more questions. I'm wondering if we could maybe put together a list of them and possibly send them to you, Jennifer and Sue, and you've already given us so much time, but if maybe we could send them and see where they go. If possible, if you could answer them, we'll send them out to our crew. I will pass it over to Paul and Deb to wrap up, but I want to express my thanks to both of you for your time, your preparation, for your valuable information. I'd like to thank our Integrative Practice Webinar team. They've been putting together this series, so much work, so much wonderful stuff behind the scenes. I want to thank all of our participants. We wouldn't do this if there wasn't interest, and we really, really appreciate you being on. And finally, to Paul for moderating, and Deb for your amazing work to pull all of this together. So let me turn it over to Paul and then Deb to close.
Thank you. And again, I'm sorry I didn't have any webcam or anything, no visuals. Oh well.
Yeah, it's life.
Glad to have the voice.
Yes, such a wealth, just a wealth of knowledge. I appreciate your time. We could probably go on for another 2 hours easily. So many nuggets and things to explore.
Thank you all, and sorry for technical difficulties here and there, but I think we're all used to that in this new age of Zooming and webcam sharing. So again, appreciate your time, both Sue and Jennifer, and
for those of you who didn't get your questions answered, please do email them to me, and we'll see if we can get those over to Sue and Jennifer and get some answers to you all.
Absolutely,
Sounds
happy
good.
to share. And hopefully you guys, if this gets a good response from the people who are signed up, you know, there are other providers and systems like we talked about, Nan Sudak, who couldn't be here today. If you ever want to do a deeper dive or have some other voices on the same topic, I think there's a lot of ground to cover.
And even Dr. R.T. Prasad might be interesting because she's running a department now, you know, and trying to bring her integrative skills into the oncology place there, as well as, you know, grow this as a field in our system.
Absolutely.
Okay. All right. All great. So thank you again, everybody, for your time. I think Beth will go ahead and close out the webinar now. But again, any questions, feel free to contact me. And again, thank you all for your time.
Thank you.
Okay. Thank you. Have a great day.
Thank you all.
Thank you.